Okay, so um, you send over a ton of research on managing non-radicular neck pain.
Yeah,
It looks like you're prepping for a lot of patients.
you're telling me.
Don't worry, we've got you covered in this deep dive. We're going to break down the guidelines, treatment options.
Even some therapies to avoid.
Yeah, exactly.
Definitely important.
So, neck pain, it's a really common problem.
Oh, it is.
Almost as common as low back pain.
Did you know about 10% of adults experience neck pain at any given time?
Wow, that's a lot of people.
It is?
But the good news is that most of these cases, they don't actually lead to serious complications.
Right.
But those more persistent cases,
Yes,
those can be really tricky.
they can.
So any advice on how to approach those?
Yeah, so first we have to make sure we're all on the same page about the types of neck pain.
Okay.
Your sources really highlight the importance of differentiating between acute, subacute,
Yeah.
and chronic neck pain.
Right. And those time frames are really important because how we treat it is going to depend on how long that pain's been going on. So
Exactly.
what are the official cutoffs again?
Okay, so think of it like this. Less than 6 weeks.
Okay.
That's acute.
Mm-hmm.
Between 6 and 12 weeks, we're calling that subacute.
Got it.
And then anything longer than 12 weeks.
Okay.
That's chronic.
So chronic neck pain territory.
Yes.
All right. I'm curious, what's the first line of defense for these patients,
So,
regardless of, how long they've been suffering?
yeah, no matter the initial approach is surprisingly similar.
Oh, okay.
So think conservative care,
Okay.
patient education,
Mm-hmm.
posture adjustments,
Okay.
even tweaking their sleep positions,
I like it.
and of course a home exercise program.
Oh, right. And speaking of posture, one of the diagrams you sent actually shows the ideal head and neck alignment.
Yeah.
And it's amazing how just sitting up straight, chin tucked, slightly shoulders back,
Yeah.
I'm doing it right now.
Yeah.
And I can already feel a difference.
I know, me too.
Who knew I was carrying so much tension in my neck?
I think we all do.
It's wild.
Yeah. So you know when patients feel a difference, right?
Yeah.
With these simple changes, they're much more likely to buy into that whole treatment plan.
Totally makes sense.
Right.
And I remember one of the studies you sent really emphasized reassuring patients, even if they have abnormal findings on imaging.
Yes.
Is that because those findings might not be the actual source of their pain?
Yeah, a lot of times they're not.
Interesting.
It's like taking your car to the mechanic.
Right.
You know, a worn tire doesn't automatically mean your engine is about to blow.
Right. Yeah.
Those imaging findings could have been there way before the pain started
Interesting.
and may not be the culprit at all.
Okay, so reassure them, mobilize them, and get them on those home exercises.
Exactly.
What kind of exercises are we talking about here?
You're going to love the simplicity,
Okay.
neck rotations,
Yeah.
tilting the head side to side, gentle forward bends,
Mhm.
shoulder rolls,
Classic.
all those classics. Yeah.
Yep.
And scapular retractions. Those are key for strengthening those muscles that support the upper back and neck.
Right. There's something about strengthening the deep neck flexors too, right?
Yes, absolutely.
Okay.
Those deep muscles, they play a critical role in supporting the head and keeping everything aligned.
So it sounds pretty straightforward, but I imagine actually getting patients to do the exercises. It's a
Oh,
whole other story.
yes, it can be.
So any insider tips on how to improve adherence?
Visuals.
Okay.
You know, think handouts with clear diagrams,
Mhm.
maybe even links to videos demonstrating the proper technique.
Oh, that's a good idea.
Yeah, when patients can see what they're supposed to be doing, they're much more likely to do it.
That makes sense.
Right.
Now, why is active patient participation so crucial in the first place?
So
Well, it seems like a simple concept, but I'm guessing there's a deeper reason.
it's about shifting the mindset
Okay.
from passive patient to active participant in their recovery.
I like that.
Early mobilization and engagement are key. We're not just trying to mask the pain.
Right.
The goal is long-term improvement and empowering those patients to take control of their own well-being.
I love that.
Yeah.
So we've got the movement piece down,
Yes.
but what about medication?
Okay.
What are our go-to options when patients need a little extra help managing their pain?
So this is where your clinical judgment comes in,
Yeah.
you know, considering factors like the patient's medical history and individual needs.
Mhm.
But generally, our first-line choices are going to be NSAIDs or acetaminophen.
Now, I've heard some folks advocate for combining NSAIDs and acetaminophen.
Yeah.
Is there actually any benefit to doing that?
I used to think so too,
Uh,
but one of the articles you sent specifically addressed this.
yeah.
Turns out combination therapy doesn't actually provide any additional benefit
Wow,
for
really
this type of neck pain, yeah.
interesting.
So we're better off just sticking with one or the other.
Okay, good to know.
Yeah.
I'll definitely be adjusting my recommendations based on that. So what happens when those first-line meds just aren't cutting it?
Okay.
What's our next move?
If that pain is still interfering with their daily life,
Yeah.
we can consider adding a muscle relaxant,
Okay.
but just for a short period.
I don't.
Options like tizanidine,
Hmm.
baclofen,
Yep.
or cyclobenzaprine can be helpful,
Yeah.
but we've got to remember those potential sedation issues.
Right, especially with our older patients.
Exactly.
Cyclobenzaprine can really knock people out.
Oh,
Evening dosing for that one, for sure.
for sure.
Now, what about those really tough cases where even muscle relaxants aren't providing enough relief?
Okay, so if we've exhausted all those options, we might consider a short course of tramadol.
Hmm.
But we really have to be cautious here.
But
There's always that risk of abuse and dependence.
Right, of course.
So it's crucial to monitor closely, start low, go slow.
Makes sense. We don't want to create more problems down the road.
Right.
Now, are there any patients that we'd want to refer for, specialized care early on?
Absolutely. We need to keep a really close eye on patients with severe pain,
Mm-hmm.
those who have experienced whiplash,
Okay.
and anyone with those risk factors for developing chronic pain.
Yeah.
These folks might benefit from a physical therapy referral sooner rather than later,
Right.
ideally around that 4-week mark.
I see. So we're trying to be proactive here.
Yes.
But why is that 4-week point so important?
Right.
What's the rationale behind early intervention?
For these patients early, targeted intervention can make a world of difference
Okay.
in their long-term outcomes.
Got it.
They might need more specialized exercises or hands-on techniques to really address specific issues.
Yeah.
Plus, we want to prevent that acute pain from becoming a chronic problem.
That makes a lot of sense. Now, you mentioned whiplash.
Yes.
Are there any specific challenges that we need to be aware of when managing these patients?
Yeah, whiplash is unique
Okay.
because there are often psychosocial factors at play.
Oh, right.
Think depression, anxiety, even fear of movement, all of which can impact their recovery.
Right. So it's not just about fixing their neck. It's about understanding their overall well-being.
Exactly.
Now, what about those red flags for chronic pain risk?
Okay.
What should we be looking out for?
It's all about recognizing patterns.
Mhm.
Are they struggling with daily activities?
Oh, yeah.
Are they experiencing mood changes?
Got it.
Do they catastrophize their pain?
Right.
These are all signs that a referral for cognitive behavioral therapy.
Let me beneficial.
So we're talking about therapy to help them reframe their thoughts,
Yes.
develop coping mechanisms.
Exactly.
And when would we typically make that referral?
Ideally around that 6 to 8 week mark,
Okay.
if the pain is persisting despite our best efforts.
Okay, so we've covered acute neck pain pretty thoroughly.
I think so.
But what about those cases where the pain just won't quit?
Yes.
Those subacute and chronic neck pain patients.
That's where things get really interesting.
Oh, boy.
And where our expertise as GPs is truly put to the test. I'm ready.
But don't worry, we've got this.
Okay.
We're going to unpack all the strategies for managing these more challenging cases
Okay.
in the next part of our deep dive.
Can't wait.
Uh,
All right. So we're back
they are.
and ready to tackle those trickier neck pain cases.
Yes.
The ones that just linger beyond those initial weeks.
Right.
So where do we even begin when we're faced with, subacute or chronic neck pain?
Okay, well, if those initial conservative measures haven't worked,
Yeah.
it's time to dig a little deeper.
Okay.
So we've got to consider additional steps like imaging
Mm-hmm.
and a formal physical therapy referral.
Imaging makes sense.
Right.
Helps us rule out any serious problems.
Right.
But physical therapy seems to be like a recurring theme here.
It is.
Almost like a secret weapon
It is.
in our neck pain arsenal.
It really is.
So what can we tell our patients to expect when we send them off to PT?
Well, a good physical therapist is going to start by explaining the anatomy of the neck
Okay.
and the patient's specific condition in a way they can understand.
Right.
They'll also cover proper posture and body mechanics.
Yeah.
Those everyday habits that can make a huge difference.
So we're arming them with knowledge right from the start.
Yes.
What happens next?
Next comes the hands-on assessment.
Right.
So the therapist will evaluate the patient's range of motion,
Mm-hmm.
checking for limitations or any tight spots.
Okay.
And then based on that assessment,
Yeah.
they're going to create a personalized exercise program tailored to that individual's needs and abilities.
So I'm picturing like, all those classic exercises we talked about earlier, neck rotations,
Yes.
tilts, shoulder
Oh, well,
rolls, all that good stuff.
they're definitely in the mix.
Right.
But physical therapists have a whole toolbox of techniques.
Yeah.
So stretching, manual therapy.
Okay.
They might even use modalities like ultrasound or electrical stimulation to manage pain and inflammation.
It's much more comprehensive than I initially thought.
It is.
It's not just about, handing them a sheet of exercises and
Mhm.
sending them on their way.
No, not at all.
Now, something I think a lot of GPs overlook
Yeah.
is that communication between us and the physical therapist is so important.
It is so important.
So when we make that referral,
Mhm.
let's give the therapist as much information as possible.
Right.
Medical history, imaging findings,
Yes.
our goals for therapy.
All of that.
The more they know, the better they can help our patient.
Exactly. The more, the better.
So we're not just passing the baton, we're actually collaborating.
We are.
I like that.
Yeah, it's a team effort.
Now, remember you mentioned some specialized types of physical therapy.
Yes.
Can you tell us a little bit more about those?
Yeah, so one that's gaining a lot of traction,
Pun intended.
pun intended,
Nice.
is motor controlled training.
Okay.
So it focuses on retraining those deep neck flexor muscles we talked about.
Right, those crucial muscles that often get weak
Yes.
in people with neck pain.
Exactly.
So what does motor control training actually involve?
So think of it like teaching those muscles to work together efficiently,
Okay.
like a well-coordinated team.
I like that.
The therapist uses specific exercises and feedback to improve muscle activation and coordination, which can be incredibly helpful for those with chronic or recurrent neck pain.
It's like we're fine-tuning the whole system.
We are.
Now, what other specialized PT approaches are out there?
So another one making waves is mindfulness-based physical therapy.
Mindfulness.
Yes,
That seems to be popping up everywhere these days.
it is.
And for good reason.
Yeah, it's pretty great.
But how does it fit into physical therapy for neck pain?
So it's all about helping patients become more aware of their body sensations, their thoughts and emotions.
Okay.
And this increased awareness can help them identify and break those harmful movement patterns,
Yeah.
reduce fear and avoidance,
Interesting.
and ultimately gain a greater sense of control over their pain experience.
So it sounds very empowering.
It is.
Now, how long does a typical physical therapy program last?
That really depends on the individual
Okay.
and the complexity of their condition. So for acute pain, it might just be a few weeks.
Got it.
But for chronic pain, we're often looking at several months or even longer.
Okay.
So the key is to regularly reassess
Yeah.
and adjust the program as needed.
So it's not a one-size-fits-all approach.
Definitely not.
All right, let's shift gears a little bit and talk about those more interventional treatments.
Okay.
When do those come into play?
So we typically reserve those for persistent cases that haven't responded to the more conservative management. And even then, it's not a decision we take lightly. These procedures have their own set of risks and benefits.
Of course.
So careful patient selection and informed consent are absolutely essential.
Okay, so let's walk through some of those interventional options.
Right.
What's in our toolkit when those tough cases land on our doorstep?
Okay, so one we've touched on already is trigger point injections.
Right.
Remember those tight, painful muscle knots?
Right.
These injections deliver a local anesthetic,
Okay.
sometimes combined with a corticosteroid, directly into those trigger points.
And those can provide pretty immediate relief, can't they?
They can, sometimes lasting for weeks or even months.
Wow.
But it's not a magic bullet.
Right.
We still need to address those underlying muscle imbalances,
Okay.
ideally with physical therapy.
So it's about short-term relief and long-term solutions.
It is.
What other interventions do we have up our sleeve?
Okay, so for neck pain, that's coming from the facet joints, those small joints that connect the vertebrae.
Yep.
We might consider a cervical medial branch block.
Okay, break that down for me. What exactly is a medial branch block?
So it involves injecting a local anesthetic
Okay.
around the nerves that supply sensation to those facet joints.
Got it.
It can help us figure out if the facet joints are the actual source of the pain,
Interesting.
and it can also provide therapeutic relief.
So it's like a diagnostic and therapeutic tool all in one. If the block successfully relieves the pain, does that mean the facet joints are the culprit?
It's a strong indicator,
Okay.
and it might open the door to a more permanent solution.
Okay, what's that?
Radiofrequency neurotomy.
Now that sounds intense.
It does.
What exactly is involved in that?
So it's a minimally invasive procedure
Okay.
that uses heat to disrupt those pain-transmitting nerves.
Interesting.
And for some patients with chronic facet joint pain, it can provide really long-lasting relief.
Wow, we're getting into the high-tech stuff here.
We are.
But I imagine these interventions aren't without risks, right?
You're absolutely right.
Okay.
That's why we reserve these for carefully selected patients who haven't found relief through other means.
Makes sense.
And of course, a thorough discussion of the risks and benefits is crucial.
Yeah, informed consent is paramount.
It is.
Now, I want to circle back to something we talked about earlier,
Okay.
which is the psychosocial aspects of neck pain.
Yes.
We discuss, CBT and mindfulness.
Right.
But what other strategies can we use to support our patients who are really struggling emotionally?
So one often overlooked aspect is stress management.
Okay.
Stress can really amplify pain.
Yeah, that makes sense.
So teaching patients simple techniques like deep breathing or progressive muscle relaxation can be surprisingly effective.
Yeah.
Even just encouraging them to take regular breaks throughout the day can make a difference.
So it's all about giving them tools to manage their overall well-being.
It is.
Not just the physical symptoms.
Yeah, exactly.
What other support can we offer?
Sometimes simply connecting with others who understand what they're going through can be incredibly powerful.
Right.
So support groups or online forums can provide a sense of community and validation for those who feel isolated by their pain.
Yeah. I can see how that would be really helpful.
Yeah. Knowing they're not alone can make a world of difference.
Totally. Those are great suggestions. I'm feeling a lot more equipped to handle these challenging neck pain cases now.
Good. I'm glad.
But before we wrap up this part of our deep dive, I have to ask.
Yeah.
What advice would you give to those GPs who are feeling a bit overwhelmed by all these options?
Yeah, I know the feeling.
I mean, there's a lot to take in.
There is.
So when you're faced with a really complex case, it's easy to feel lost.
It is.
What do we do?
So remember, we don't have to have all the answers right away.
Okay.
Sometimes the best first step is simply to listen.
To our patients.
To your patients, yeah.
Okay.
Hear their story. Acknowledge their frustrations, validate their experience.
Yeah.
Often that simple act of listening can really build trust.
That's true.
And open the door to a more collaborative approach to treatment.
Empathy. That's always a good place to start.
It is.
What else should we keep in mind?
So don't underestimate the power of a thorough history and physical exam.
Right.
Imaging is helpful, but it's not the be-all, end-all. And remember, our mantra, conservative care first. Start with patient education, posture correction, home exercises, and simple analgesics.
Those are our foundations.
They are?
And if those aren't enough?
Then we can start exploring those more targeted therapies.
Okay.
Physical therapy, manual therapy, trigger point injections.
Got it.
And if we've truly exhausted all of those options, then we have our second and third line medications.
Right.
And those specialized interventional procedures as a last resort.
It's about choosing the right tool for the right patient at the right time.
It is.
And if we're still feeling stuck.
Don't forget, we have a whole team of specialists to call on.
Oh, right.
Physical therapists, pain specialists, mental health professionals.
We're all in this together.
We are.
Working towards the common goal of helping our patients find relief and improve their quality of life.
That's the goal.
What a great reminder that we're not alone in this journey. Now I'm really excited for part 3.
Me too.
Where we're going to put all of this knowledge into practice with some real-world case studies.
Yeah, that'll be good.
So stay tuned. Okay, so we're back and ready to put all of this neck pain knowledge into action.
Yes.
I love a good case study. It really helps everything click into place.
Me too. Let's see how these principles play out in real-world scenarios, like what we see every day in general practice.
Okay, so first up, imagine a 35-year-old office worker walks in complaining of neck pain and stiffness for the past 2 weeks.
Okay.
They spend hours hunched over a computer.
Yeah.
And the pain gets worse in the evenings. No history of trauma or any red flags.
Okay.
Where do we start with this patient?
So this is like the classic desk jockey.
Right.
Sounds like a textbook case of mechanical neck pain, likely exacerbated by, you guessed it, poor posture.
So we're thinking conservative management for this patient.
Absolutely. First and foremost, we need to reassure them that this is a common problem and, more importantly, a treatable one.
Yeah.
We're going to talk about the importance of good posture and ergonomics.
Yeah.
Those frequent breaks and stretches can make a world of difference.
And I bet those simple home exercises we talked about earlier would be perfect for this patient.
You're reading my mind neck rotations, tilts, shoulder rolls, scapular retractions.
Yeah.
We'll guide them through the whole routine.
Okay.
And to boost adherence, let's provide really clear instructions or even a link to a video demonstration.
Right, because who remembers exercises from a verbal description alone?
Nobody.
Visuals are key.
They are.
Now, would we consider medication for this patient?
If their pain is mild to moderate,
Okay.
over-the-counter pain relievers like ibuprofen or acetaminophen might be all they need.
Okay.
We'll discuss the pros and cons of each option and empower the patient to choose what feels right for them.
Yeah, I love that shared decision-making approach.
Me too.
So let's say this patient comes back after 4 weeks
Okay.
and their pain hasn't improved despite following all of our recommendations.
All right.
What's our next move?
Time to call in our trusty ally,
Who's that?
physical therapy.
Okay.
So we'll refer them to a skilled physical therapist
Ugh.
who can provide a more in-depth assessment,
Okay.
pinpoint any specific muscle imbalances,
Yeah.
and tailor an exercise program to their individual needs.
And we'll loop the therapist in, sharing all the relevant details from our assessment.
Right.
That open communication is so crucial.
It is.
Okay, are you ready for a case with a little more complexity?
Get me with it.
All right, so picture this. A 50-year-old woman comes in
Okay.
a few weeks after a car accident. She's describing neck pain, headaches, dizziness,
Oh, wow.
difficulty sleeping, the whole whiplash package.
Yeah.
And on top of that, she's visibly anxious
Okay.
and overwhelmed by the whole situation.
This sounds like a lot more than just physical pain.
It does, right?
We're definitely dealing with those psychosocial factors.
Exactly. So we need to approach this patient with extra sensitivity,
Yes.
validate her concerns, and address any fears she might have about movement. Reassurance is key here.
Yes.
Let her know that these symptoms are common after a whiplash injury.
Yeah.
And that, recovery is possible.
Right.
But we still want to encourage her to stay active, right?
Absolutely. Prolonged rest can actually backfire,
Right.
leading to more stiffness and pain.
Yeah.
So gentle range of motion exercises
Okay.
and a gradual return to normal activities are key.
Now, given her symptoms and the mechanism of injury, I imagine a physical therapy referral would be a top priority here.
Absolutely.
Okay?
We want to get her to a therapist who specializes in whiplash-associated disorders.
Right.
They can address any muscle imbalances,
Yeah.
work on joint mobility,
Mm-hmm.
and help her regain that normal function.
And while we're at it, a CBT referral might be beneficial as well.
Yeah, that's a great idea to
Right.
help her manage that anxiety and stress that so often come with whiplash.
It's all about, addressing the whole person,
Yes.
not just the physical injury.
Exactly.
Okay. Are you ready for our final case study?
Bring it on.
Okay, so last one. A 65-year-old man walks in
Okay.
with a long history of neck pain that's been steadily worsening over the past year.
Okay.
He's tried everything. Medications, physical therapy,
Wow.
even chiropractic care.
Okay.
But nothing seems to help.
Oh, no.
He's frustrated.
Yeah.
He's losing sleep, and he's starting to feel hopeless.
I can imagine.
So what do we do
Yeah.
when it seems like we've exhausted all of our options?
So it's crucial to acknowledge his frustration
Right.
and let him know that we're not giving up.
Right.
We're going to review his medical history with a fine-tooth comb,
Okay,
make sure we haven't missed any underlying conditions,
got it.
and then we might consider bringing in a pain specialist.
A pain specialist.
Yeah.
What kind of expertise can they offer in a situation like this?
So pain specialists have advanced training in managing complex chronic pain conditions.
Okay.
They can offer a broader range of treatment options,
Okay.
including more specialized medications, interventional procedures like nerve blocks,
Okay.
or even spinal cord stimulation,
Wow.
and even comprehensive pain rehabilitation programs.
So we're basically expanding our support network, calling in reinforcements
We are.
to provide, the best possible care for this patient.
Exactly.
And remember, even when we've explored all of the conventional medical avenues,
Yeah,
there's still so much we can do.
there is.
We can guide them towards those non-pharmacologic pain management strategies, connect them with support groups,
Yeah.
encourage mindfulness practices,
Right.
anything that helps them regain a sense of control
Right.
and improve their overall quality of life.
Exactly.
It's about empowering them to become active participants in their own healing journey,
Yes.
even when the path is, long and winding.
Beautifully said, and sometimes the most powerful medicine we can offer
Yeah.
is simply our presence, our empathy,
Right.
and our unwavering commitment to walking alongside them through those challenges of chronic PON.
That's a really valuable reminder that, we may not always have a quick fix,
Right.
but we can always offer compassion and support.
We can.
Well, I think we've covered just about everything there is to know
I think so.
about managing non-radicular neck pain.
Yeah, it's been a great deep dive.
Any final words of wisdom for our listeners before we wrap up?
Just a few key takeaways to keep in mind.
Okay.
So, conservative care is our first line of defense, always.
Yes.
Patient education and active involvement are essential for success. Don't hesitate to loop in specialists when you need to.
Right.
And never underestimate the power of a strong, compassionate patient-doctor relationship.
Absolutely. Great advice. Thank you so much for joining me on this incredible journey into the world of neck pain.
My pleasure. It's been fun.
I feel like I've leveled up my GP skills today.
That's great.
So that's a wrap for today's deep dive.
Okay.
Thanks for joining us.
Yeah, thanks, everyone.
We'll see you next time for another deep dive
Sounds good.
into the fascinating world of medicine.